So my lecture is about the role of ultrasound in the management of obstetric complications. One of the most common complications in developing countries, and particularly in Africa, is the uterine fibroids. Now, you have a lot of different types of fibroids. The vast majority of them are benign tumors, and they are found in about 20 to 50% of women of childbearing age. Now, large fibroids, especially those who are in the lower segment, close to the cervix, can obstruct the labor or be responsible for fetal malpresentation like breech, oblique, or transverse. So they're extremely important in that context in the management of a complex delivery. This slide shows you a typical fibroid of the anterior wall of the uterus, which is in the upper part of the uterus, should not be therefore responsible for a malpresentation, but the same sort of size fibroid, which is between 5 and 10 centimeters in the lower segment, may be responsible for fetal malpresentation. So that's essentially what maternal complications are about in terms of ultrasound diagnosis, and now we're going to concentrate on the fetal condition which can have obstetrical consequences. The most common one is obviously malpresentation. We will then discuss multiple pregnancies, talk about specific fetal anomalies that can be associated with obstetric problems, look at abnormal fetal growth, then placental anomalies, and finally we will discuss polyhydramnios. Starting with fetal malpresentation, you have essentially breech, which is found in about 3 to 4% of pregnancies at birth, and transverse, which you will find in about 0.3% of pregnancies at birth. Now, the consequences of these fetal malpresentation is, number one, obstructed labor. If the labor is prolonged, the fetus eventually may die in utero, intrapartum fetal death. And if, fortunately, there is access to a cesarean section, it's very likely to be a very complex cesarean section, especially when the fetus is in transverse presentation. Multiple pregnancy gestation, twins and triplets, other pregnancies are quite rare, are also a major obstetrical issue. Now, multiple pregnancies, there are two types of main twin pregnancies. The dichorionic twin pregnancies, where there are two placenta with two amniotic cavities who are completely separated. You find this in about 1.2% of all pregnancies. The monochorionic pregnancies, where you have one placenta with one or two amniotic cavities, are found in about 0.4% of the twin pregnancies. And this slide shows you the different type of twin pregnancies. The dichorionic diamniotic twin pregnancy, which is the most common one, the dichorionic monochorionic twin pregnancy, which, as I said, represent about 0.4% of pregnancies, and then the very rare monoamniotic monochorionic twin pregnancies, which are an extreme version of the monochorionic diamniotic twin pregnancies, combining all the risk factors plus the risk of cord entanglement during the pregnancy or during childbirth. The mortality for the fetus compared to singletons is much higher in twins and triplet pregnancies. The neonatal mortality, which is mainly linked to fetal growth restriction or premature delivery, is increased by 4.5 for twins and more than 9 times for triplets. Once the babies have been born, there is still a mortality at 1 year, which is increased by about 6 times, and the risk of cerebral palsy for twins will range between 3 and 7 times what is found in singleton pregnancies, and for triplets is increased by at least 10 times, all depending on the type of twins or triplet pregnancies that you're dealing with. The mortality for the mothers in a twin pregnancy is increased by 3 times compared to a singleton pregnancy, and in triplets by about 6 times. And this is mainly due to complications such as preeclampsia or hypertension, anemia, diabetes, cholestasis, and complications during delivery such as difficult emergency cesarean section or postpartum hemorrhage, which is one of the major problems of multiple pregnancies. This slide is showing you an ultrasound view of a dichorionic twin pregnancy, where you can clearly see the large septum separating the two gestational sacs. It is a very thick membrane which is made of 4 layers and which separates the two gestational sacs. In this case, you can see that the two placentas are almost fused, so it could be confusing if you didn't look at the membrane, because you would think that because there's only one placenta to be seen, that it could be a monochorionic twin pregnancy. You can clearly see that the septum is made of these 4 layers and is very thick, and you can see the lambda sign, which indicates that this is definitely a dichorionic twin pregnancy. You can also see the histopathology of placentas from a dichorionic twin pregnancy and from a monochorionic twin pregnancy. You see how much thinner the membrane is in a monochorionic twin pregnancy. Obviously, the main complication which happens in 15 to 20% of monochorionic twin pregnancy is a twin-to-twin transfusion syndrome. That's a very important notion to have, and that's why it's very important to identify the type of twin pregnancy that you have as early as possible during the pregnancy, because as long as you get this diagnosis at 12 weeks, then you can prevent and follow up the patients in a different manner. If you miss that opportunity at 20 weeks, it's extremely difficult to diagnose the difference between a monochorionic and a dichorionic pregnancy. And it's only when you have a full-blown twin-to-twin transfusion syndrome that you will realize the situation. Fetal congenital anomalies leading to obstetric complication include fetal hydrops, which happens in about 1 in 800 live births, anomalies of the fetal head, hydrocephaly and anencephaly, which happens in about 1 in 1,000 live births, and anomalies of the fetal abdomen, exomphalus omphalocele, which is found in about 1 in 5,000 live births. There are other much rarer complications that can also obstruct a labor, like a megacystic or dilated bladder, some form of bowel obstruction, or some fetal tumors. But these are anomalies that are so rare that they should not be really a major problem and major issue for those who are doing routine ultrasound scans. Fetal hydrops is one of the most common symptoms in fetal medicine. The definition of fetal hydrops is an abnormal increase of fluid in the skin, in the placenta or the cord, in the amniotic cavity leading to polyhydramnios, or in various body cavities, the abdomen, ascites, the chest, pleural effusion, the heart, pericardial effusion, and in male fetuses within the testis, the hydrocele. Fetal hydrops is a non-specific finding which is classically divided into immune fetal hydrops due to maternal, essentially hemolytic blood disorders, or non-immune, which covers all the other etiologies. The etiology of the non-immune fetal hydrops include mainly fetal chronic anemia, fetal cardiac failure, a decrease of the venous return, or hypoproteinemia when the liver is involved. And one of the most common causes of non-immune hydrophytalis in developing countries is congenital infection. Overall, it only accounts for about 5% of the causes of non-immune hydrophytalis, and it happens mainly in the second and third trimester. But considering the larger incidence of infection such as Coxsackie, Toxoplasma, CMV, or parasitic disorders such as leptospirosis and trypanosomias, these causes are much more common in developing countries. You can see here on this slide the aspect of a typical Down syndrome trisomy 21 fetus at birth in the second trimester. This is the time of Potter, who described these non-immune form of hydrophytalis. Obviously now with the development of ultrasound, we rarely see these at deliveries if they are being diagnosed early in the pregnancy. And ultrasound has been a major player in identifying fetal hydrops from as early as 10 weeks of gestation enabling to make a diagnosis before there is a requirement for the mother to give birth. It is now the most common ultrasound feature in fetal medicine. Most features can be diagnosed from the end of the first trimester with a standard ultrasound machine. One of the most striking features of fetal hydrops is the presence of skin edema, which can be detected from around 10 weeks of gestation. This slide shows you the fetus with the skin edema of the forehead and the enlargement of the placenta, which is typical of the placental edema that's found in case of fetal hydrops. This slide shows you the enlargement of the skin around the fetal head at the level of the BPD measurement, which is also typical of a major fetal hydrops. Another common feature of fetal hydrops is its association with polyhydramnios, increased amniotic fluid. This slide shows you a twin pregnancy complicated by twin-to-twin transfusion syndrome with a massive accumulation of amniotic fluid in the recipient sac and the donor stuck in the upper part of the slide. This slide shows you the fetus of the previous slide with the enlarged placenta and the skin edema associated with a massive enlargement of the amniotic cavity due to accumulation of amniotic fluid. This slide shows you two examples of ascites, which can also be diagnosed from around 12-14 weeks of gestation in the vast majority of the cases, and is an easy ultrasound diagnosis. Pleuroeffusion is also an easy diagnosis. You can see two examples of accumulation of fluid inside the chest. This slide shows you a fetus with a single accumulation of fluid inside its chest. This slide shows you also a skin edema and polyhydramnios in the background. This slide shows you the huge impact that ultrasound has had over the last 30 years in improving the early diagnosis of fetal hydrops. In the 1980s, most cases of fetal hydrops were diagnosed at the end of the pregnancy between 30 and 35 weeks. In the 1990s, this diagnosis dropped with the introduction of the 20-week scan to an average diagnosis around 20 weeks. And over the last 10-15 years, it has dropped to an average of 12 weeks of gestation. And this is really showing you how ultrasound has improved not only the knowledge of people about ultrasound, but also the quality of the ultrasound machine now enables you to make the diagnosis at a very early stage, when it's still possible either to treat or to terminate the pregnancy if it's impossible to provide the fetus with treatment. Now, the important thing to remember in case of fetal hydrops developing in the third trimester is that it can also have obstetric consequences, such as obstructed labor and malpresentation from transverse to breech, which are going to be extremely difficult deliveries because of the enlargement of all the different fetal parts, and in particular for the head in case of a breech. Hydrocephaly is another important anomaly to diagnose in the context of obstetric complication. Congenital hydrocephaly results from the abnormal accumulation of fluid inside the ventricular system, resulting in an enlargement of this system. It is often caused by a stenosis of the sylvius aqueduct, or a block in the reabsorption, or a malformation in the reabsorption system, such as in the Dandy Walker and the spina bifida malformation. So it is important to know the ultrasound diagnosis of hydrocephaly before the patient goes into labor. This slide shows you various forms of hydrocephaly, all resulting in an enlargement of the fetal head circumferences beyond the possibility of engagement inside the pelvis, and therefore resulting in obstructed labor. The obstetric consequences are obvious. Obstructed labor, malpresentation are the main complication associated with fetal hydrocephaly. Anencephaly is another important diagnosis of abnormalities of the fetal head that can result in complication during labor. And anencephaly results from the failure of closure of the anterior neuropore during the embryonic phase of development, and it will resolve progressively in the absence of a cranial vault. Its ultrasound diagnosis is therefore extremely important as early as possible during the pregnancy, when the termination is feasible, because it is an anomaly that is incompatible with fetal survival, and therefore, because of its consequences on the mother during labor, it's absolutely essential that it is diagnosed early in pregnancy. So this slide shows you a normal fetus with a normal cranium and a fetus with anencephaly where the cranium has not formed and the brain is basically floating inside the amniotic cavity, resulting progressively in the erosion of the brain tissue and the full-blown anencephaly. There is no point in waiting for this to happen and to be seen on ultrasound, as the diagnosis can be clearly made at 12 weeks of gestation, enabling an easy and safe termination of pregnancy, compared to what would happen if the diagnosis was only made at 20 weeks or at term just before delivery. The consequences of anencephaly are also, like hydrocephaly, obstructed labor and malpresentation. Rare abnormalities of the fetal anatomy, such as the omphalocele, which affects 1 in 5,000 pregnancies, can also result in complication during labor. The omphalocele is a defect of the ventral wall formation of the fetal abdomen, resulting in the herniation of the intra-abdominal content, including the liver. And its main problem, if it's a major omphalocele, is that it will increase the size of the abdomen and may cause malpresentation. The ultrasound diagnosis is relatively straightforward. This slide shows you various forms of omphalocele, where the omphalocele contains the bowel or the liver. Sometimes it contains both structures, and obviously will enlarge the abdomen diameter. We're now going to talk about the anomalies of the fetal growth, and that goes from a very small fetus to a very big fetus, both of which can be associated with obstetric complications. Starting with the small fetus, which is sometimes defined as fetal growth restriction or intrauterine growth restriction, or small for gestational age, the differential diagnosis is the low birth weight, which is a neonate of a birth weight of less than 2 kilos independently of the gestational age. In case of small fetuses due to growth restriction, the gestational age is obviously an important parameter, and it's essential to know the last menstrual period of the patient before this can be evaluated. So fetal growth restriction or intrauterine growth restriction is a term used to describe a clinically small fetus that has not reached its growth potential. It's a development measure as a 10 centile for gestational age. It can have placental, fetal, or maternal causes and can affect 4 to 10% of pregnancies. This slide shows you the important measurement that needs to be acquired before making this diagnosis: measurement of the fetal head, measurement of the abdominal circumference, and measurement of the femur of the fetus. This slide shows you a normally growing fetus with its head circumference, biparietal diameter, femur length, and abdominal circumference all growing around the 50th centile. The 50th centile is a line in the middle between the two extremes of the 97th centile and the 3rd centile. This slide shows you a fetus growing around the 10th centile. You can see that in this case all the fetal measurements are growing around the bottom line, which is the 3rd centile. Measurements being just above the 3rd centile have been evaluated as being around the 10th centile. It's a normal small fetus because all the measurements continue to grow on the same line. So it is very likely that in this case the operator got the wrong date from the patient, and that the gestation might be less advanced than previously thought. Now, these things are difficult to address if the patient doesn't know her last menstrual period, which is why it is important to have an early scan if possible to measure the Crohn run length, which will have an error of maximal 6 days if well done at the time, and which will give you a much better evaluation of the fetal growth later in the pregnancy. This slide shows you an abnormally small baby which has more than one measurement below the 10th centile. All the measurements of the head, the abdomen and the femur are all actually below the 3rd centile. So this is clearly an abnormal fetus. It is essential in this case to check for other fetal malformation, exclude a trisomy 18 or triploidy or a congenital infection. The growth can be symmetrical or asymmetrical, and so it is also important to assess the amniotic fluid volume and the fetal activity, which can be normal or decrease. It's rarely increase, but the fact that you find another malformation indicates that it's an abnormally small fetus linked to another complication, such as an aneuploidy. This slide shows you the measurement of a star fetus. So it's an abnormally small fetus, but this is not associated with a fetal abnormality, it's associated with a placental insufficiency. The growth will be asymmetrical. The abdominal circumference will tend to be smaller than the fetus, which will tend to be smaller than the head circumferences. In those cases, the fetal anatomy is normal. There is reduced amniotic fluid and fetal activity, and the uterine Doppler and the fetal Doppler can also be abnormal. There are two different types of etiology of placental insufficiency. They usually classify in primary, due to genetic anomalies, chromosome mosaic syndromes, or secondary, maternal disease, hypertension, diabetes, infection, radiation, drug, tobacco, which had a cytotoxic causes, and environment, altitude, pollution, or diet. The obstetrical consequences of fetal growth restriction in that case can be quite extreme and result in the fetal death or placental rupture, with all the consequences of the alteration of the maternal coagulation resulting in disseminated intracoagulation, DIC. At the other end of the spectrum of abnormal fetal growth is the macrosomia. A macrosomic fetus is a newborn with an excessive birth weight which is above the 90th centile for gestational age, after correcting for sex and ethnicity. About 10% of fetuses are born with a weight over 4 kg at term, and about 1.5% are born with a weight of about 4.5 kg at term. The facts associated with macrosomia is obviously that they will continue to increase after full term, and that the fetus will be much bigger than what you would expect a fetus to be at 41 weeks, while the most common association between fetal macrosomia and maternal condition is maternal diabetes and poor maternal diet. It has become one of the major obstetric problems in the Western world, and the consequences of fetal macrosomia are shoulder dystocia, major vaginal trauma during childbirth, obstructed labor, postpartum hemorrhage, and in prolonged obstructed labor, intrauterine fetal death. How to diagnose macrosomia clinically is sometimes quite complicated, especially in obese patients. So ultrasound is often the only way that you can have for an accurate diagnosis of an abnormally big baby. This slide shows you the measurement of a macrosomic fetus. You can see that in all the measurement, the head measurement of the BPD, the abdominal circumferences and the femur lengths, the measurements are above, in this case, the 97th centile. It is often also associated with excessive amniotic fluid with polyhydramnios. And polyhydramnios is something that it's easily diagnosed by ultrasound, and so it is worth spending some time learning about the origin and the consequences of polyhydramnios. Polyhydramnios is the excessive amount of amniotic fluid in the second or the third trimester. It's a common complication of diabetes and macrosomia. It can be associated with fetal anomalies and fetal hydrops, and one of the common fetal anomalies is a fetus not swallowing if there is an obstruction of the esophagus connecting the mouth and the stomach. It's also a common complication of twin-to-twin transfusion syndrome. 80% of polyhydramnios are mild and idiopathic, i.e. there is no obvious causes for the excessive amniotic fluid. It can be found in around 1% of all pregnancies at around 20 weeks and over. The obstetric consequences of polyhydramnios are preterm labor, unstable fetal lie, and compression of the maternal diaphragm resulting in difficulties for the mother breathing. The ultrasound diagnosis of polyhydramnios is very straightforward. This slide shows you a typical ultrasound picture of polyhydramnios. There is a massive increase of the amount of amniotic fluid in the amniotic cavity. The amniotic fluid index, which is commonly used to define polyhydramnios, is the sum of the vertical measurement of the largest pocket of amniotic fluid in 4 quadrants of the uterus, and the total has to be above 20 centimeters. A simple way of measuring also is to take the maximal vertical measurement of the largest single pocket of amniotic fluid, free of fetal part, and it will define a mild polyhydramnios if it's between 8 and 11 centimeters, a moderate polyhydramnios if it's between 12 and 15 centimeters, and a severe if it's 16 centimeters or more. The first thing to do is obviously to exclude fetal anomalies, pedal hydrops, absent stomach, diaphragmatic hernia, trisomy 18, skeletal dysplasia, and maternal diabetes. Polyhydramnios is important to diagnose because it leads to premature labor, and the use of amniodrainage with a syringe, or if there is access to a drainage bottle, can make a huge difference in the risk of premature delivery. It is safe and efficient for all causes of polyhydramnios, including those associated with twin-to-twin transfusion syndrome. Placenta previa is a well-known complication of pregnancy, which results in a dramatic obstetric outcome if not diagnosed before delivery. The definition of a placenta previa is the insertion of the placenta in the lower segment of the uterus. It is found in about 1% of the scans at 20 weeks and 0.5% at term pregnancies. Only 0.1% are major placenta previa in the 3rd trimester. They have been classified in 4 types. Type 1, the low-lying placenta. Type 2, the marginal placenta, which is reaching the internal os of the cervix. Type 3, which is a placenta partially covering the internal os of the cervix. And type 4, which is the entire placenta inserted inside the lower segment on the cervical os. The obstetric consequences of the placenta previa are well known: maternal bleeding, preterm labor, unstable lie, and it is essential to make a difference in diagnosis between placenta previa and placental abrupture. It is essentially done clinically, but if the placenta previa has been diagnosed antenatally at an earlier stage, then it is a very straightforward differential diagnosis. And this is clearly an important ultrasound diagnosis which should be part of all routine ultrasound examination. Basic ultrasound examination must include the placental position, and this slide shows you 2 cases of posterior low placenta where the placenta is between type 2 and 3, partially covering the cervix or completely covering the cervix at 20 weeks of gestation. This slide shows you a major placenta previa at 20 weeks of gestation where the placenta is covering the entire lower segment from the bladder to the posterior wall, passing over the cervical os. There is a role for transvaginal ultrasound examination in case of placenta previa when the placenta is posterior. As you can see in this slide, the fetal head is obstructing the view and it's very difficult to see the placental edge with the transabdominal examination. Or in the same case, if you use a transvaginal examination, you can clearly see that the placenta is a type 3 placenta. It's not only reaching the os, but also partially covering the os, and it's clearly an indication for a cesarean section. This slide shows you what happens to the placental position between 20 weeks and 32 weeks. At 20 weeks, the placenta may look previa, but with advancing gestation and the formation of the lower segment, you can clearly see here that the placenta is nowhere near the cervix as at 2 weeks as compared to 20 weeks. The head, as shown by the arrow, is clearly covering the cervix, and the placenta has moved in the upper part of the lower segment. It is still a low placenta, but it can be expected at 40 weeks to be completely outside the lower segment and therefore enabling for normal vaginal birth. In summary, it is important to have basic knowledge of ultrasound, because ultrasound can identify complications that can have an impact on labor and maternal mortality or morbidity. So ultrasound can help in the diagnosis and the management of these maternal fetal complications that can be responsible for obstetric complication and resulting in maternal death. And that's including fetal anomalies, which represent about 0.5% of all pregnancies, fetal growth restriction, which can affect up to 5% of pregnancies, fetal macrosomia, which affects 1 to 2% of pregnancies, polyhydramnios, 0.5% of pregnancies, placenta previa, at term major placenta previa, 0.5% of pregnancies, and fetal malpresentation, which affects about 4% of pregnancies. So in total, ultrasound can identify 12% of fetal or maternal complication that can have an impact on labor and can affect the mother during a delivery. So it's essential that these 12% of complication are identified before labor so that the mother can be offered a different management which will help avoiding a major catastrophe during labor.